Hi everyone, my name is Matt Jensen and I'm an emergency, trauma and critical care registered nurse. This is an in-service presentation I wrote a few years ago on the comprehensive respiratory assessment. It's aimed at new grad emergency nurses or nurses who are inexperienced with a respiratory assessment. If you'd like a copy of the slideshow for your own use, please just email me using the address provided in the blog post. I do ask that you reference me as the creator of the PowerPoint, however. Alrighty, let's get started with our learning objectives. Today, we're going to gain an appreciation of why we should conduct thorough and comprehensive respiratory assessments, understand the anatomy of the thorax and how the structures are connected, increase our knowledge of how to carry out an appropriate respiratory assessment in the emergency setting, and finish with learning how to interpret a chest radiograph. Why do we carry out respiratory assessments on our patients? The respiratory assessment is a critical part of a nurse's patient evaluation. It can provide information about acute and chronic disease processes, and it guides intervention and treatment. A quick review of the anatomy involved. The lungs are a pair of organs that occupy the majority of the thorax. Responsible for ventilation and oxygenation, the lungs are made up of the trachea, the bronchi, the bronchioles, and the alveoli. The lungs are surrounded by the pleura, comprised of a double layer of membranes, separated by a serous lubricant separated by the membranes themselves. The visceral pleura coat the lungs, and the parietal pleura is attached to the inside of the chest wall. Between these two layers is the pleural cavity, a potential space that allows for the expansion of the lungs during inspiration. The right lung is made up of the middle and lower lobe. The left lung is made up of the upper lobe and the lower or posterior lobe. The space where a middle lobe would be is occupied by the heart. The pulmonary arteries and veins run out of and return to the right side of the heart and the left side of the heart, through the hilar and branch off into the smaller vessels that reach the alveoli to facilitate gas exchange. The thorax is a bony structure that contains and protects the lungs, the heart, the great vessels, and to a smaller extent the organs of the upper abdominal cavity. It is comprised of the bilateral clavicles, the true ribs that number 1 through 7, the false ribs 8 through 10, and the floating ribs 11 and 12 that only attach posteriorly to the spine. Centrally, the sternum originates superiorly with the jugular notch, the manubrium, the angle, the body, and the xiphoid process. Posteriorly, the thorax is anchored at the thoracic spine with vertebrae numbering 1 through 12. The liver is partially protected by the lower ribs on the right-hand side and the spleen by the lower ribs on the left. How do we carry out a comprehensive respiratory assessment? When carrying out a respiratory assessment, we use the same framework as on all our other body system assessments. We begin by inspecting. Inspecting involves a purposeful observation of the patient by looking and listening. We assess for respiratory rate by counting for respirations for 1 minute or at least 30 seconds and doubling, and noting whether their rate is normal, tachypnic, bradypnic, or shallow. We assess the rhythm of the patient's respiration. A normal rhythm has an inspiratory phase followed by a slightly longer expiratory phase with a short pause before the next cycle begins. Men are more likely to use their abdomen or their diaphragm for breathing, whereas women are more likely to use their intercostal muscles. All chest wall movement should be equal, bilateral, and symmetrical. We should always assess for cusmal respirations, which are deep and rapid breathing, often associated with the metabolic acidosis and seen classically in the patient with diabetic ketoacidosis. Chain-stroke respirations are classically defined as periods of apnea alternating with periods of shallow and laboured breathing and is associated with imminent death in the patient. Quality of breathing is assessed for by observing for a symmetry in the chest wall movement. Bronchial obstruction, fibrosis, or collapse of the lower lobes can all cause failure of the chest wall to rise adequately. Similarly, the pleuritic pain associated with pneumothorax can cause a patient to shallow breathe and thus suffer alveolar hypoventilation. Work of breathing is assessed for by observing for use of accessory muscles, in particular the sternocleidomastoid and the trapezius muscles around the necks and shoulders. This indicates respiratory distress as the patient is having difficulty breathing and is air hungry. The use of pursed lips or nasal flaring should also be noted. Pursed lips is a symptom of over-distended alveoli and is an attempt to force air out at the end of expiration, and this is seen classically in the patient with COPD. Nasal flaring is a sign of respiratory distress, and it's usually observed in the neonatal or infantile patient. The skin color of a patient is important to note, as cyanosis shows that the patient has a large volume of desaturated hemoglobin caused by a failure of ventilation or circulation. Peripheral cyanosis is usually indicative of poor circulation and is noted around the nail beds and extremities, and central cyanosis is indicative of either poor circulation or poor ventilation and is noted around the lips and under the tongue. Clubbing of the distal fingers is a sign of chronic hypoxemia from either pulmonary or cardiovascular origin. The thorax should be examined for anterior to posterior versus side to side diameter. If the front to back diameter is equal to or greater than the measurement of the side to side, then the patient should be assumed to have a barrel chest caused by emphysema. If the patient has a reduced level of consciousness, the causative agents of hypoxemia or hypercapnia should be considered. An oxygen-starved brain or carbon dioxide-washed brain will induce a comatose state. Either of these causes require immediate action and escalation, as they can both cause irreversible brain damage. We must always consider confounding factors when carrying out a respiratory assessment. The pregnant patient may have increased fluid retention, which can cause edema, and the enlarged gravid uterus can cause decreased lung expansion. The obese patient may have extra thoracic weight, which can impede lung expansion, and we need to be particularly mindful of how we position these patients in bed, as their habitus can greatly impede their respiratory function. Using our other clinical assessment skills, we should look for known or unknown circulatory problems, such as pulmonary edema or anemia, which can negatively affect gas exchange, or abdominal pathology, where any condition that displaces the diaphragm can cause respiratory compromise. An example of that would be severe bowel obstruction. Moving on to auscultation. The nurse should auscultate the chest with a stethoscope. Begin by placing the diaphragm of the stethoscope on the patient's right chest at the second intercostal space, and then compare side to side, listening for a full respiratory cycle at each side. Move down the chest and towards the lateral aspect of the lungs. Then carry out the same examination on the patient's back, listening to the posterior aspects of the lungs. There are several different types of normal breath sounds. Vesicular sounds are low-pitched, low intensity, and are heard over the majority of the lung field. Bronchiovesicular sounds are heard anteriorly over the mainstem bronchi and posteriorly between the scapula. Bronchial sounds are high-pitched, loud, and hollow, and are only heard over the larger airways and the trachea. Abnormal breath sounds. Crackles are discontinuous, non-musical, brief sounds usually heard during the inspiratory phase. They can either be fine, high-pitched, soft and brief, or coarse, low-pitched and louder. You want to listen to the pitch, duration, timing during the respiratory cycle, frequency and location of the crackles. Crackles are associated with consolidation from either pneumonia, fibrosis, bronchitis, or pulmonary edema from left heart failure. A wheeze is associated with obstruction of the airways caused by bronchospasm or obstruction. Most commonly caused by asthma, the wheeze should be assessed for duration and involvement of the expiratory only or inspiratory and expiratory phases. The longer the duration of the wheeze and involvement of the inspiratory phase indicates a more severe pathology. An audible wheeze is suggestive of a 50% reduction in the lumen of the airway and should be taken as a serious sign of airway compromise. A pleural rub is caused by a loss of lubricant between the two layers of the pleura. It is often described as a sound like treading on fresh snow. As the pleura slide during both inspiration and expiration, a rub can be heard during both halves of the respiratory cycle. It is most commonly associated with pleurisy, pulmonary embolism, and pneumonia. A stridor is a serious and late sign of upper airway obstruction. A stridor will begin as an inspiratory sound, and as it progresses, will transition to both inspiratory and expiratory. It can be caused by stenosis, swelling, physical obstruction, edema from burns, tumours, and angioedema from allergic reactions. It requires immediate action from both senior, medical, and nursing staff. We then move on to palpation. You want to place the palm of your hopefully warm hand on the patient's chest and feel for vibration. Palpate gently for surgical emphysema, felt as rice bubbles or bubble wrap under the skin. Using two hands on the anterior lateral aspect of the chest, feel for bilateral chest wall movement at the points of exhalation and maximal inhalation. If chest wall movement is not symmetrical, it can indicate severe fibrosis, not allowing for lung expansion, or chest wall damage limiting movement. At this point in the live presentation, I would ask for any questions from the participants. I left the slide in the online delivery of the presentation due to the excellent nature of this GIF. We'll now move on to interpreting chest x-rays. We always begin by ensuring we're looking at the correct patient. Patient identifiers have obviously been removed in this film. Next, we determine whether we're looking at a posterior-anterior film or an anterior-posterior film. PA films are preferred as they are usually higher quality and allow for accurate measurement of the heart. AP films are usually taken in a resus or critical room or in the trauma bay and are done so because the patient is either too unwell or unable to go to radiology for a formal film. They are usually lower quality and don't really allow for accurate measurement of the heart and mediastinum. PA projection allows for the patient to sit or stand facing the detector, which means that the radiation passes through the patient posteriorly to anteriorly so that the structure of the chest are closer to the detector. AP projection means that the patients are facing the source of radiation and the beam passes through them onto a detector behind them. If we compare between PA and AP films, we can see how the relative position of the heart to the detector can influence its projected size. The analogy I always use when talking about this concept is that if you imagine you're in a dark room with a torch or a flashlight and you place your index finger immediately in front of the beam of light, you will have a much larger shadow on the wall than if you placed your finger in front of the beam at arm's length. Now we're going to have a look at one way to systematically analyse a chest x-ray. This follows an alphabetical path that I conglomerated from a few different sources. It's certainly not the only way to look at a chest x-ray, but I find that if I follow a system, then I do it the same way every time and I miss things far less frequently. A is for airway. We want to make sure that the airway, the trachea, is central and patent. We want to look for an ETT, make sure if one is positioned that it's positioned appropriately, and we want to be able to see down to the level of the carina. We can also get an indication of whether the patient is appropriately rotated by looking for the thoracic vertebrae shining through the trachea from behind. B is for bones. Are all the bones intact? Are there any obvious fractures or rotations? And how many ribs can we count? We should be able to see between 8 and 10 ribs on a good inspiratory film. I start by looking through the clavicles and following them from the lateral edges all the way through to the center of the chest, looking for fracture or rotation. I then cast my eyes over each individual rib, superiorly to inferiorly, looking for fractures and counting as I go. In the trauma patient, you pay particular attention to fractured ribs, making sure you don't have any signs of a flail chest segment, which is identified by 2 or more fractures in the same rib with 2 or more fractures in contiguous ribs. We then move on to our cardiac silhouette. We should be able to see the great vessel of the aorta as it comes up, turns around, and then plunges behind the heart. This is known as the aortic knuckle. We also should be able to measure the heart. It should be no bigger than 50% of the total thoracic width on a PA film. We want to make sure that we have nice crisp edges and angles where the heart meets the diaphragm. That then means that D is for diaphragm, other sides grossly equal. The right side of the diaphragm will rise slightly higher, about 1 to 2 centimeters, because of the liver. We want to check and make sure that the costophrenic angles are sharp. If they are not, we need to consider the likelihood of a pleural effusion or consolidation. In the COPD patient, the diaphragm will appear flattened due to chronic overexpansion of the lungs. E is for equal lung fields. This is where we check for pneumothorax. We follow the lung markings out to the edge of the lung to check for pneumothorax. We do want to differentiate between the line of the scapular bone shining through from behind and an actual pneumothorax. The way to differentiate between the two is to follow those lung markings all the way out to the edge of the thoracic window. We then look at the fields themselves. Are there any obvious patchy infiltrates in the lung fields? And if so, where are they? We want to look for curly B lines and interstitial markings. Curly B lines are horizontal lines, usually about 2 centimeters long, found in the lower lobes, and are signs of either pulmonary edema, malignant lymphoma, pneumonia, sarcoidosis, or fibrosis. We then look at our gastric bubble, which may or may not be present. In the erect patient, any stomach gas is going to rise to the highest possible level of the stomach as it weighs less than the stomach contents themselves. This will show up as an encapsulated bubble. We differentiate between a normal gastric bubble and free air under the diaphragm, with free air under the diaphragm appearing as a long, thin line that rides up along the bottom line of the diaphragm itself. We need to correlate this finding with history. A post-laparoscopic surgical patient will have a deliberate pneumoperitoneum, but in a patient with acute belly pain, we need to think of or consider perforation of a hollow viscous organ. Now we consider the hilar and the mediastinum. Firstly, is the mediastinum widened? The hilar is where the pulmonary arteries and veins branch out into each lung. The mediastinum is the membranous partition between the two lungs. It should be no larger than 8 centimeters on a PA film. Causes of the widened mediastinum include air leaking from either the trachea or the esophagus into the pleural space, or blood leaking from one of the great vessels. Think an aortic shear injury from deceleration in trauma patients. And then we finish with I for impression. What is happening with this film? This is a terrific image from the wonderful website Life in the Fast Lane with all the major anatomy highlighted. I guess the final question then, is it even possible for us as emergency nurses to carry out such a comprehensive respiratory assessment on all our patients? History Channel guy says, yes it is. Here are all my references from this presentation. If you have any questions, clarifications, corrections, concerns, or compliments, please don't hesitate to reach out to me via my provided email address. Thanks for your time.